No, we do have a panel that I think should add far more to your life than my little story just did. It deals with rural health care, which is obviously an area of tremendous opportunity, and I think also an area of some concern for a lot of folks in South Dakota. Just tremendous upside, but also want to make sure that we play that future out properly. And we've got three very good panelists with us to help. First off, we've got Jay Weems, who's Executive Director of Avera's e-care health services. And that's really, I suspect a number of you know, but it's really a visionary model that allows for 24-hour access in rural areas to pharmacists and physicians. Really is making a difference out there. We've also got Rebekah Cradduck, who I got to know as a very good former legislator and peer, had a number of leadership roles she played there. And she's got a lot of experience, but not the least of which has been in critical access hospitals for more than a decade. And obviously those are a huge component to making sure that rural parts of our country are well served from a healthcare perspective. And we've also got Dr. Daniel Heineman, the Assistant Vice President of Health Policy. And it takes a special kind of person to be an excellent physician and then also be able to transition over to being an excellent person to understand public health policy. Those are two very different spheres, plenty of overlap, but also a different set of skills and abilities that it requires to be as successful as Dan has been. So we're going to follow roughly the same format. I'm going to throw a question out to a lead respondent. The other panelists will pile on, and then we want a conversation with you. And if anything, we want it to be a little bit more engaging, a little bit less formal. So please feel free to pop up, raise a hand, we'll get you a mic, and you can be a part of the discussion. That is where I suspect a lot of the value is going to be added. So without any further ado, let's ease these guys are nervous, I'm sure. Let's give them a round of applause to make them feel a little more welcome before we get started. So the first question we will throw out will be to Jay, and it's going to deal with the geography issue, which is such a big issue when it comes to rural health care. I mean, how do we get the specialty services that, we all know that communities Sioux Falls and larger have? How do we get those kind of specialty services available to places like, Platte and Wagner and Flandreau and Red Owl and all parts of South Dakota? Thoughts?
Thanks, Dusty. First of all, to solve this problem, it's not unique. It's been there for a long time in rural healthcare. And growing up near Doland on a farm, our closest access to a hospital was about 25 miles away. So I knew at a young age, as Mom would take me to the ER room for all the misadvents I'd had, that time is really important. And it's really important to get access to lots of different specialties, not only to an emergency room, but to a cardiologist or a pulmonologist. And so one of the tactics that we've used at Avera is, we call it e-care, but leveraging telehealth. And telehealth, if you're not familiar with what telehealth is, it's just like the video screen you see up above. It's streaming video. So you literally have a specialist in their office here in Sioux Falls or Rapid City that would use two-way video and see a patient in Miller or in Parkston or Chamberlain or any of our small communities that have another video unit. And that's telehealth. And telehealth's been with us for over 25 years. The issue has always been, and I'll kind of make it real for you, as you watch the news, you see the correspondents overseas talking, and they'll ask a question, and you have that delay of 2 or 3 seconds. That's latency, or just the communication lines of how much time it gets there. Well, 15 years ago, not only would you have that time delay, but their lips would be moving, you wouldn't hear anything. I think you all can remember that. Now, with our telecommunication infrastructure, we can stream video just like you see it here today. You can see and talk to a physician from Sioux Falls or Rapid City to Parkston or a Miller or a Chamberlain. So technology has kind of got us to a spot where we can take these specialists and drop them in on our small rural communities. I want to give you a couple examples of taking that maybe to a different type of level. 2 years ago, we launched a program where we put these two-way video systems into emergency rooms. And when you think about our rural communities and the people you live with, in our small towns, the doctor's a family practice doc. You probably have a mid-level provider like a physician assistant or nurse practitioner to support your hospital. They're a family practice physician. They're not a specialist. And I know growing up, and I gave you a little bit of an example, that trauma happens, farm accidents happen, and speed is extremely critical. And we have great quality care in our rural communities, but family practice docs just don't get a lot of time on trauma events. They simply would maybe have 100 to 200 events over the course of a year. Why not take a specialist, a board-certified emergency physician that sees 50 patients a day and help support that family practice doc, and then in turn support your loved ones? So how does this happen? Let me give you a real example. Car accident happens. This is a true story. In a small town in rural South Dakota, it was a two-car accident, head-on collision, 7 people injured. Obviously, that would overrun a small community hospital, and it did. They brought these injured patients into the small hospital. This hospital was wired with e-emergency. And what happens with that is you literally have a doc with his hands in his pocket in the room supporting that hospital. Obviously, he can't touch because he's through two-way video, but he can see that patient. He can triage that patient with the supporting nursing staff in that local hospital. So what happened in that 7-patient car accident is that our physician helped in one room and they triaged it, right? You take care of the worst case first. In the same time, in our hub that this physician works in, we have a critical care nurse who then saw immediately, and the local staff said, look, we're going to need some transportation out of this community. Some of these folks are pretty seriously injured. And they'll coordinate the transportation out, whether that be a helicopter, plane, or ambulance. So now we have the local nurses having the support of a physician to help with the patient, and they don't have to leave to try to find a hospital to take the patients. They don't have to leave to call for transportation. It's a game changer, I think, in healthcare when you have immediate access to a physician now in your emergency room, along with the supporting physician. Your local physicians are still the primary docs. They still run the show. But now they have support, like they did in the residency program where they had a team of specialists behind them. Now we can bring a team of specialists through video. I'll give you another type of service. We call that, the last service we call e-emergency. The next one is EICU. Same kind of concept, only this time not only we're streaming data, but we're streaming data and video. So if you have a loved one in the hospital, I'll pick on Miller. Joe, my table mate, is from Miller. He has it in his hospital there. If you have a loved one in the Miller Hospital, they're hooked, and they hook them up to EICU. It's simply a bed in the hospital that's wired with two-way video, and it has data, and we can see literally everything that's happened in that room. And at our hub, we have a board-certified intensivist watching that patient, and we leverage, this is where technology comes in. We have a software. It's developed by Philips VisiQ. And much like some of the things you use in your farm production, this is a monitoring system that you set ranges and it tells you oxygen levels. So when oxygen level drops, you can call on the local staff and say, hey, we need to take a look at this patient. So literally you can have someone in the room 24/7 watching your loved one. So what does that mean? Well, instead of sitting in a hospital in Sioux Falls or Rapid City, they can stay local. And why is that important? Well, we know that patients heal quicker when they're in their local hospital. We know that when families there, it gives them the support they need. And we also know when folks travel to Sioux Falls or Rapid City or bigger communities, they're going to spend money overnight, they're going to spend money on food. Why not keep that economic local? And they can stay in their own home, and they can buy gas in their own town, and they can buy food in their own hometown. So we think that's a significant improvement in what has happened in rural communities for healthcare. Finally, I'll end on another service that's also fairly new, but really important. It's around patient safety. Right now in your small towns, you probably have one pharmacist. They probably work in the local drugstore, and then they cover the hospital. One thing we know is medication errors do happen. And 60% of the medication errors can be prevented if you have a pharmacist review that order before administration. So why not take that same concept of putting a hub together with pharmacists, beam them into that small hospital, and review those orders for that nursing staff and for that physician staff to prevent those medication orders. Another really, really important aspect to prevent harmful administration of medications. And with hospitals being more wired, we can do this by looking at their electronic medical records. We can see if there's interactions, and we can really take care of our loved ones. It's really building a virtual hospital. We believe that if you can keep patients local, build that virtual hospital over those small towns, that you can keep patients there, you can provide high quality care, and and probably most importantly, the economics, you can keep it local.
Thought from Dan or Rebekah. I mean, anything to add or criticize about that? He can't have everything exactly right.
Well, I'm just going to give you an example of access, and technology is going to be really very helpful. But an example of where policy and legislative efforts have made a difference in our healthcare in South Dakota. Probably about 3 years ago now, a task force, or longer, probably 5 years ago, going into 3 years ago with some legislation, a task force on trauma was set up in South Dakota, and trauma system legislation was brought forward in a legislative session and passed. And what that trauma system legislation has done is it really has upped the standard and upped the care for all of our local ambulance services across the state of South Dakota, because you really don't have a choice where you have a car accident or you have an accident or an injury, and you're really placing yourselves in the hands of the individuals who arrive on the scene, stabilize you, and transport you to a local facility and then on to a trauma facility, and maybe even, God, which wouldn't happen, but out of state to a level 1 trauma service. The trauma system legislation was good legislation that led to some policy around what we expect in our local hospitals, ambulance services, in terms of training and expectations. So it's a combination of hospitals, systems, policy, legislation, and I think we're going to rely a lot on technology in the future. And then I'm going to talk a little bit later about, it's great to have all this technology and it's great to have all this stuff, but if you don't have people on the other end to make that connection, it's not going to work very well either. So
we'll see how I project. I don't disagree with anything that's been said, and I would be supportive of everything that's been said. But I think in the broader sense, as those of you that live in very, very rural areas of our state, as well as frontier, rural, and non-urban, access is a different discussion. And what we're talking about and what we've heard this morning so far is basically tools to assure access, which the technology brings, and then some public policy via the trauma that got put in place and again gets implemented locally. So you have, in the policy arena, you have the macro going on, the state legislature and others, the governor's office leading that effort. But then it has to be implemented. And many of you know, being in rural South Dakota, that keeping volunteers for your ambulance service is your real effort. And all the technology in the world isn't going to get you the human that's going to be in that driver's seat and the person that can deliver trauma or emergency care on the highway in your rural community if in fact you don't have those volunteers. So there's a lot of moving parts that keep all of the access issues local. And so you've heard some tools and some policy discussion.
Well, the question, asked about how do you provide some of those specialty services to rural areas? I mean, is technology really the only way that gets done?
I'll take a stab at that. No, it's very helpful in that it helps to provide a service more efficiently. It's not very efficient to move a specialist, a limited specialist, from a large area to a small area. It's a couple of hours on the road, it's in an airplane, it's not very efficient. And there's a lot of downtime associated with the movement of that specialist, if you will, into a small rural community. It happens a lot. There are a lot of cardiologists, there are a lot of surgeons, there are a lot of maternal fetal medicine specialists, obstetricians, you name it. There are a lot of specialists in limited areas that are spending an awful lot of time either in an airplane or in a car driving to places. but it is not very efficient, and that's where electronic technology, where applicable, will be very helpful. Because now a physician could be seeing a patient in their office, the next room is equipped for telecommunication, they go in and they see that patient just like they're in their office, and then go to the next patient, which is actually in their office. When we get to that and we can figure that all out, we'll have greater access for things like surgery, cardiology. Psychiatry works very well, and we have a real serious problem with behavioral health in South Dakota and access to it. So it is going to be helpful. But as I'm going to talk to you about in a little bit, you got to have the physicians to be able to do that.
I'll just pile on a little bit about, and I'd agree with that. The whole art of this, too, with access, you can have the greatest access so we can beam folks in. But if, I really think it comes down to patient accountability, personal accountability. And growing up on a farm, I watch my mom and dad, and I watch them get older now. And in South Dakota, we all know this is coming. We've got, I think in the nation, there's 13% of the Americans that are over 65, and in South Dakota, it's 18%. I read a stat that the population growth in South Dakota from 2000 to 2020 is going to be 13%, yet those 65 and older is going to grow at 49%. So you got a big wave coming, and we know it's coming. So you got to quickly get the access in there so you can support it, and our healthcare system can't support everyone in the hospital. Obviously, that's the most expensive arena. So you're going to see, as you watch healthcare reform start coming, and it has started, is how do we prevent that? How do we have population-based health? How do we make sure that in our rural communities, people are much more active in their own health, and that it's easy? And I think the key here is we talk about if you have the labor pool to beam in, make it easy. So Dan talked about specialists coming out, and they do that a lot, and they'll pick a day, right? It's Monday, they come out every other Monday. Well, if the sun's shining, at least I remember when my dad was farming, if the sun's shining, you're out in the field, you're not going to stop. What if you could give them more flexibility so that appointment could be moved to a Wednesday? That's what we're really talking about, is make it easier so our farming community can get in and see the physician, and it's not every Monday or every other Monday. It's just easier to do. One thing that Rebekah touched on, and Dan, is a little bit about regulations. I think one thing we're experiencing in healthcare is regulation has not kept up with technology. There's certain regulations that really prohibit from us really helping rural America, and there's quite a bit of efforts, I know, on both health systems on a national level to try to drive legislation that makes it more advantageous for rural communities to get access to health care.
Well, and I've got a slew of questions about that, but again, in the interest of trying to make this as interactive as possible, if there are questions in the field about this access issue, let's take them.
Dusty, one of the questions that came up was around the technological advancements. How do we promote the types of technological advancements you mentioned, video conferencing, et cetera, so rural folks know that it's available, and more importantly, so potential residents, people looking to settle in our rural communities, know it's available? So promotion of those assets.
I'm just going to bring forward another technology that's rapidly taking place in South Dakota, and that's an electronic medical record. And many of our communities, through our systems, and if you will, it's really around, a lot of it around the three big health systems in the state, are rapidly implementing electronic medical records. And electronic medical records are shared medical records with a specialty practice, with a primary care practice, and the movement of that data and that information and those images, those CT scans, those x-rays, the ultrasounds, a variety of things are moving at light speed, if you will, literally across the state. So not only will we be able to use telemedicine or telehealth technologies, but also using our electronic medical records, and we can get at the data that's required to manage populations, to manage health, to look at where do we have pockets of problem, if you will, in the state of South Dakota. So that's another technology I want to lift up as one that's going to be a real big plus for us going forward, because you can't manage what you can't measure, and so being able to measure it is really important, and that's what electronic medical records will help us to work with.
On the community awareness, this is one of those that you as leaders in your community can really take a hold of, and as you go back home, talk to your hospital administrator, your clinic manager. You probably know people that are on the board of directors of the hospital, and say, do we have this technology? And one of the things that works great is open house in hospitals. A lot of you, I've seen some renovations of hospitals where they have an open house and you can see the new addition or an updated rooms. And you really need to be active, and I'd encourage you to take ownership on that of, do we have that in our hospital and can we talk about it? Because one thing that as soon as folks realize that, and one thing in healthcare that we've learned is, and it's intuitive too, is folks always think, and it applies to my family, that if you go to the next biggest hospital, it's got to be better because it's bigger. And all of a sudden now folks know that they've got access to specialists in Sioux Falls or Rapid City. They don't have to go to the big city. They can stay local and they can get that great quality care right here because they have the support. And all of a sudden you'll see the volume in your clinics and people staying local increase. And community awareness, it comes down to folks like you, grass level, of making sure you know where it's at.
So, Jay, does that make a difference? Is there data to support the idea? Because, I know a lot of rural hospitals have made pretty substantial investments into the facilities. Do you see a noticeable reduction in leakage after those investments are made?
I think if you talk to hospital administrators, and I can't stand up for them, but what I've known from talking to a few of them, when they do that new addition on the hospital, and our elderly are the benefactors, right? Those are the folks going to the hospital say, I didn't realize we had this nice a facility. And it does make a difference, because all of a sudden the family members come from out of town and say, oh, my mom or my dad's really getting good care here in our local town. One of the things that we track that's important to us with this e-emergency service is when the hospitals use it, can we reduce transfers out? Because you hear these stories from the emergency room docs, and I'm sure it's the same at Sanford, it is at Avera, is you get these patients from smaller towns and you check them out and everything's fine and you send them back home. It's a wasted trip. And what this helps, and that doesn't happen a lot, but it happens. But what if you could alleviate that transportation cost to the health system, the cost to the patient and the third-party payer, and keep them local? And my point in all that is we've shown that our data shows about a 25% reduction in transfers. So keeping folks local, that helps the local economy. So there's a piece of data that says, hey, this does make a difference.
My follow-up led us a little astray. We should go back to Rebekah. Do you have anything to add from the question that was asked about sort of community awareness?
Well, and again, community awareness, as many of your participants know, it is, in fact, what it is. You live in your community, you know your community, you're involved in your community, and by definition, you define what is available in your community. And it's what is important. And Jay is right, as is Dr. Heineman. The promotion piece, the inviting in, the engagement is important, whether it's the K-12 system or the hospital, the clinic. Many of you don't have hospital communities, and so you have clinic communities, and so it is incumbent upon you to know what's going on in healthcare in your community. And again, I would be willing to bet that many of you are actually volunteers in your local ambulance crews, and you do participate. And it isn't just what you do, it's the network around you and what's available down the road or in the next larger facility. And Jay's right, it isn't about size, it's about what you have available in your community. But you define that, and then not only that, but you support that as a local citizen.
Another question before we move on to the next topic.
We do have one over here with Joe Fiala from Miller.
Thank you, Lucas. This question addresses the leveraging of technology, which I think is great from a small community perspective, and it allows that expertise and that medical care to come from larger centers of population to the small rural communities. My question, I guess, is that same technology should allow us to have some of those experts be based in the smaller communities and push their knowledge out to other areas, whether it's other small communities or larger? Have we asked ourselves that question? Has there been that discussion? And if so, are there positions in the healthcare field that would work in that scenario?
I'm going to take a crack at that, and I'll let you. That's going to be really very difficult. And I'm going to speak to the area of surgery or cardiology. First of all, a cardiologist can do a lot in terms of diagnostic workup with an ultrasound, a treadmill test, possibly an outreach nuclear scan. But we're not going to put a cath lab in the Miller Hospital. The equipment necessary now for a surgeon to work, I'll be honest with you, surgeons do very few open cases anymore. They're either done through a laparoscope, or many surgeons now do them through what's called a Da Vinci robot system that are a couple of $1 million to buy, and they're outdated the day they're delivered. So technology for some of those types of specialties are going to limit the size of the facility that you can provide service. And then the other part of the problem there is the volume. Many times it's like a funnel. You've got broad-based primary care referring into specialty centers and medical centers where your care gets more technical and more specific, and so that they generate the volume from the larger area. It's a good question for some of the specialties. Some of the really technical high-end specialties, it's going to be very difficult. And then the other problem where the law has not kept up with the practice, the interstate practice of telemedicine and it is very difficult. You need to have multiple licenses in multiple states, which makes it very difficult to do. Someday, we may have a national licensing program for physicians. We don't right now, so.
And I think, Joe, I think Dan's absolutely right. I think you won't be able to pull in a specialist. You look, and Dan's going to talk about workforce, and you're probably going to touch on this, just and the panel before ours talks about just ag lenders and recruitment, and you talk about specialty physicians. It's extremely competitive, and there's just not going to be that much attractiveness to small towns. But I do think I'd probably go more at the angle of, is there a way to leverage family practice on areas? So let's give you for an example is, can we pull in, maybe we're at a verge of we really can't handle one more doc, we could handle a half a doc, but you can't hire a half a doc. So what we want to do is let's hire one more physician and then use telehealth to do just maybe an urgent care type of visit. So in our big cities, we have after hours, right? Most clinics shut off at 5 o'clock. Well, in Sioux Falls, Rapid City, you get after hour clinics. Well, could you do some of that and use those family practice docs in our small town? So, I'd agree it's going to be nearly impossible to pull a specialist in a small town, but can we leverage docs that way, family practice that can work in the hospital, work in the clinic, and then also use telehealth? I think that's a real possibility. It's got to be the right mix and the right ingredients, but I think that can be done.
And just for the sake of weighing in, yes, in fact, we can do it in reverse from rural to urban, depending upon, as Dr. Heineman pointed out, the specialist. If, in fact, you would have a cadre of psychiatrists in Miller, they could certainly practice in an outreach model into the larger and broader areas of our state. The technology folks, the folks that, cut things open, probably is not going to happen. But it really depends upon, and again, I go back to the definition of your community and what you have and what you can support, and then how you make it work in the broader sense. And I think psychiatry is just one of those examples where you could actually go from rural to urban versus urban to rural.
Well, I know we've got other questions, but let's, the second question is so related to the first. And Rebekah is the lead respondent, so let's give her an opportunity to kind of give her take. Second question really deals with, how do you ensure, not just on the specialty, but in a broader sense, how do you ensure quality access to care in rural areas? Let's give her an opportunity to respond, and then we'll go back out to questions.
Yep, and Dusty, just a reminder to our panelists, if you don't mind picking up the microphones or getting them a little closer. Thank you.
Yeah, and maybe just, maybe best practice is take them out of there, and then when you're done, you can set them on the table, but that might be easier, so you can get them real close. Great. All right. Rebekah, why don't you take the first shot?
Okay. I was asked to focus my comments on access, adequate access to health care in rural South Dakota. And so I worked in rural health care, and I've worked in health care for many years. And so it's a real process, and I've thought about it, and I've talked about it many times. And I always use the example of a three-legged stool. And all of you know what a three-legged stool is. You must have all three legs. They must all be level in order for the stool to be functional. And so, you know, in my analogy of the three-legged stool, it has recruitment, retention, and access. So in the recruitment arena, you must have, there are many partners in recruitment. You have national, state, and local, and they have different responsibilities and areas that they do better than others and have to do. In the national discussion, we're talking about actually having training programs. The National Health Service Corps provides those of us in rural areas with people who have obligated service, and then we have the graduate medical education support dollars from the feds that helps to train medical professionals in our hospitals. Those are all pieces that must be part of the federal partnership. At the state partnership, those resources are in our public policy arena. We as a state must provide our children with the opportunity to get health professions education. If we don't have access to the education and training, our children don't get it, or they leave the state. And there's a lot of studies that support that once they leave for education, they don't necessarily come back to serve. So it's important in the public policy arena at the state level that we provide for college and technical training. And we also in South Dakota have a very limited loan repayment program, which communities can access. And of course then in the local community, in the recruitment arena, you have to support, there are local efforts. And again, I would suspect that many of you are involved, but it's, you know, the professional recruitment goes on via your hospital, your clinic. Many of you economic development groups have done it and are doing it. And ultimately, it is then the matching that happens. At the macro level, we need to educate enough family docs. At the micro level, you need to make it attractive enough for that person to stay in your community once they arrive. And in that way, you then move into the retention model, which again is mostly a local piece. If the person is there and they're delivering health care in your community, it is incumbent upon the local community to support their health care, whatever it is. And again, I believe that you at the local level actually define what your health care is. It's what you need and what you want and what you support, and that becomes part of the broader community discussion. In the federal and state, there are some other incentives that happen for rural that helps to enhance payments for critical access hospitals, rural health clinics, and federally qualified health centers. So that helps you, the community, not you, the human, in the retention and having a viable practice that assures then, of course, access. Access is having what you need, when you need it, where you need it. And again, at the local level, the super subspecialists, by efficiency and support services and requirements, are not going to be there. You may want everything, but that doesn't necessarily mean that you're going to be able to support it and keep it in a viable operation. So in the rural communities, we really look at more of the primary care model and access to making sure you get channeled correctly into either using the tools that have been brought in or getting you referred appropriately, and then hopefully your primary care provider is then managing, and you're working with that person to actually get referred out, get referred back, get the rehab locally, or actually have it resolved through the different tools in your local hospital, which is one of those resources. So again, and each of those three each of the legs of that stool, have an hour's worth of discussion, which I won't do for you. Could, but I won't. I think it's important coming out of here that you, the audience, the participants in this, healthcare is not necessarily your primary concern in ag. And I understand that, but in healthcare, for me, healthcare is the primary concern in all communities. So it is local. Every conversation about healthcare is local. And you make decisions at the community level that are based on what your family needs are, what your ambulance service access issues are, and it's kind of like there are a lot of resources out there, and you need to reach out to resources, and that's part of that community PR piece. You need to find out what's available. Ask the question of your local, whoever is doing the recruitment, economic development, hospital, clinic. Get involved, find out, ambulance service, and find out what's going on in your community, and have the discussion on whether or not it is what you want, and whether or not you want something more or different than what you have right now. Defining adequate is impossible, because each of you define adequate based on your own needs locally right now. And so for us, at the macro level, the definition takes on a viability discussion, an efficiency discussion, use of resources, and whether or not it's efficient to have the cardiologist travel out and spend a lot of windshield time or airport time to see 2 or 3 patients versus having the 2 or 3 patients either seen via technology or having them shipped into the larger urban areas. And again, that becomes part of the community discussion on what it is you want, reaching out, talking to, again, we have 3 large systems in our state. Depending upon your geographic location, there's always folks that are willing to engage in those conversations and talk to you about what you want to do, what you see as being important, and then building towards that. And again, it's not an overnight thing. I used to laugh. I started a long time ago in recruitment, and that's part of that training that goes on in your career. People would actually call me on Friday because their doctor was leaving on Monday. And they thought perhaps, I guess I had them in a closet somewhere and I could just ship them on over. Well, we've gotten way past that model of recruitment knowledge base, but it is a long-term commitment. And unfortunately, our partners with the Department of Health aren't with us, and I won't speak for them, even though I will anyway. But there are resources available to you from the Department of Health via the Office of Rural Health. And again, many of you perhaps are even doing this, and you just haven't put it in the larger structure of where you fit in. But in the Department of Health, in the Office of Rural Health, there are pieces that happen all the time. Designations, community designations, provider designations. This becomes access for you in the community on whether or not you can recruit doctors, PAs, nurse practitioners, nurses that have obligations to serve in rural America. And so your community must, in fact, do an application and be designated on an annual basis in order to participate in that program. And then the providers who are graduating must, in fact, process. They kind of have to, especially if they're scholarship. But if they're loan repairs, they're looking for the federal loan repayment program, which is very lucrative. And so they're looking for a match. You become the community that matches with that provider. But that happens at the state level. If you're not engaging with the Office of Rural Health and your community isn't participating in that designation process, you're missing an opportunity to do recruitment, and that leads to retention. The other piece that goes on in the Department of Health, in the Office of Rural Health, that is very significant is, and as you all know, we must in fact educate our children on the careers in healthcare. And we compete with everybody that wants our kids to go into our professions. And I don't like to share a panel with the general contractor folks because they want everybody to go into, construction. And I want everybody to go into healthcare. But at the Department of Health, in the Office of Rural Health, there's a program called the HOT program. And the HOT program actually does K through 12 curriculum. They bring health professionals locally into the school system to educate kids about the health professions. It's way broader than doctor, nurse, physical therapist. There are several career paths in healthcare. And we put together a book that goes out to the high school counselors that the kids can access, and it's on the web because we're trying really hard to be technical. And so there are opportunities, but again, it begins at the conversation at the kitchen table. Your children and you as a family unit make micro decisions on what your kids are going to do, where they're going to go to school, what career they're going to go into. They then make decisions on where they're going to practice. We, at the macro level, of course, hope that they all go into primary care and they all come back to South Dakota. But you're going to make the decisions with your children on what's best for them. And we wouldn't fault you for that, but I would guilt you into doing primary care. But that's the smallest circle of the whole discussion of access. And it's all the moving parts that have to work together in order for you to have access in your community and nationally and internationally. So
let's throw it back out to the crowd. I mean, at some point we're going to want to get Dan and Jay's take on all of that. But Lucas, do we have questions?
Yeah, thank you. I think it's more of an extension of Joe's earlier question around the legal ramifications, or are there legal concerns from a doctor at a satellite location to be giving medical advice to an off-site location? How do you mitigate that?
Well, I'm going to tell you that there always are, no matter what you do in practice, there's potential risk. A physician's going to have a liability insurance, going to have coverage. It's going to include that type of work. You're always going to want to make sure that you're within your scope of practice, that what you're doing is appropriate, and that it meets the standard of care and you're not going to get into any trouble. But yeah, those are some of the things that physicians, when they ask or get asked to participate in these types of programs, ask, and we have to make sure that the state laws cover that and that you have adequate liability insurance.
Just one thing to add to that is these physicians will be privileged and credentialed in that hospital, so there's a review process that the local community makes, and just to echo what Dan said, at the end of the day, it's going to be that specialty provider's decision whether they want to practice or through telehealth.
I just wanted to add one more thing to Rebekah's discussion about the three-legged stool. One of those legs is adequate payment for services. Beginning Friday in South Dakota, anywhere from 11 to close to 0% reduction in Medicaid payments is going to begin to take place. And some of our facilities rely a lot on Medicaid payments. That's going to start to put some stress on those facilities. In fact, I think there's a hospital, and if I'm not mistaken, it's the Martin Hospital, that is threatened to close on Friday or their next fiscal year because of payment issues with the Indian Health Service. So payment issues, adequate reimbursement for services, et cetera, play a huge role and part in making sure that we have adequate access for both physician or for hospital providers, and as we're going to talk about in a second, physician providers.
Go ahead.
We do have another question from the floor. There was mention of the importance of and need for volunteer first responders, EMTs, firefighters, as the first line of healthcare in rural areas. The question, whose responsibility is it to build a robust volunteer EMS system? Is it government, hospitals, local community?
Well, that's a really good question, and there is no answer because, again, I go back to that local discussion. By virtue of the fact, and I'll use a term that perhaps isn't kind, but the providers that ride in the ambulance are pre-hospital. And they have, again, within the Office of Preparedness, That is where they are physically managed. And there's some licensing pieces, and there's different levels of licensure for people that provide ambulance service. And the volunteer ambulance service really is a local community piece. To my knowledge, there is no government support other than education training for volunteers. And we have some other grant-driven projects right now. The Helmsley Grant is supporting some training with the 12-lead product through the Heart Association, and then also the simulator process to help with training that you can't do on humans when they're alive and well, CPR, et cetera. So there's different types of training going on. And of course, the other piece to the pre-hospital folks is the radio piece, which is another part, and that's located over at the Bureau of Information and Technology, and how you communicate and what talk groups you're involved with, and how you get, as an ambulance, the person, Joe, who's driving the ambulance in Miller, you know, he gets on the radio and he's talking to somebody. He knows who he's talking to locally, and they make decisions locally. Now, how they get volunteers, that's like a local arm-twisting event, to my knowledge. They go out and they recruit. I know that some of our rural hospitals, and I would let Jay and others talk to this, but I know that some of our hospitals actually employ the volunteers, and so that they have, they're in the community, and there's some releasability depending upon what their job is in the hospital on their ability to leave and take ambulance call. And one of the biggest problems right now that I'm hearing about is the 8 to 5, Monday through Friday kind of thing, because in the Sioux Falls catchment area, many of the volunteers actually work outside of their community, so they're not physically there to go to the ambulance and take call. So you have nights and weekends covered, but not necessarily days. But to my knowledge, there is no organized recruitment of, and that becomes a local piece.
And I just add, my answer to that question would be it needs to be local. It needs to be the local community. Each community, one thing that I've learned in traveling to different critical access hospitals, these are small hospitals, is they're all unique. They all have unique needs. They have a unique physician makeup, a unique administrative makeup. So I think you keep this local, and you give them tools like telehealth technology, the trauma, that they can provide the services they need to provide. On the question that Rebekah made about how do you ensure adequate access to health care, you know, I think, and Dan I'm sure is going to touch on this, it's really about that physician team that you put together, that medical team, whether it's the nurse and the physicians. You've got to have a team around that. It's no longer 20 years ago, 30 years ago, where the primary care doc is the captain of the ship. These new physicians coming out are used to working inside of a team, so you really got to provide that support mechanism. It's really generational as you think about the next generation of farmers coming through. Is they're much bigger. Your operations are much bigger. It's not unlike healthcare. They're used to working on a very large facility. They're used to, I saw an iPad out here, used to having iPads and they can see the electronic medical record, and now you want them to go to a small community that doesn't have an electronic medical record yet, and oh, by the way, you're going to pull call every other day. And when you have a competing offering, and I'm tripping over what Dan's probably going to talk about, you know, you can take call 1 out of 20 days in a bigger community. So we'll probably touch on that in a minute.
Yeah, and that's probably as good a segue as any into the third question, which really does deal with how do you get enough bodies, qualified bodies, to take care of this medical need we've got. Dan?
Well, let's see if I can help answer that question. First of all, I grew up on a farm in Del Rapids, and my experiences surrounding the smell of bacon and eggs were a little different. They were a little earlier in the process. And the governor and I were in the same 4-H club together, and I haven't checked lately to see if that 4-H club is still in existence, but I need to do that. I'm a family physician, and I'll need to tell my colleague to the right that I'm a specialist. And family medicine is a specialty. I practiced for 20 years in Canton, and now I work in both as a chief medical officer and in health policy at Sanford. And I want to give you some numbers around South Dakota, and they may make you a little bit nervous. These were back in 2009, some of them. We have roughly about, I would say today we have about 1,900 to 2,000 active physicians in South Dakota. We probably have about 750 primary care physicians. Primary care physicians are defined as either pediatrics, general internal medicine, or the bulk of our primary care physicians in South Dakota are family physicians. We roughly had about 450 female physicians, which is another interesting demographic and does play into some of the struggles we have in smaller communities. We have about 20% of our 12% of our physician population are international medical graduates. They were trained outside of the United States, come to the United States for residency, and then through various visa programs, stay in communities. So that's about 12 to 13%. I want to give you some statistics that I think will bode for what some of the solutions may be for what we do in South Dakota. I'm a positive statistic for South Dakota. I'm a native, did undergraduate, medical school, and residency in South Dakota. And if you can get that combination, especially medical school and residency, roughly 80% of those folks stay in the state of South Dakota. If you just go to medical school in South Dakota, about 40% come back or practice in South Dakota. If you just do a residency in South Dakota, again, about 40% of those folks stay in South Dakota. Now, understand, to get to be a practicing physician, you go to undergraduate, you go to medical school, which is 4 years, and then you have to do a minimum of a 3-year residency. Family medicine's 3 years, internal medicine's 3 years, pediatrics 3 years, neurosurgery on the long end of that is about 7 or 8 years, and then anywhere in between for the various specialties. We don't have, but here are the residencies we have in South Dakota. We have family medicine, we have 2 programs, 1 year in Sioux Falls and 1 in Rapid City. We have a pathology program, a psychiatry program that has both child and adult psychiatry. We have pathology, we have internal medicine, and we just started last week a pediatric residency here in South Dakota. Those are the residencies that we have. And so that's our only chance to keep physicians in South Dakota. We graduate 50 students every year from our School of Medicine. That should be about 65. But that would be anywhere from $2 to $3 more million of funding for the School of Medicine, which it hasn't been able to get in the last number of years. Residency programs are also very expensive to start. Most graduate medical education, which is a residency, is actually funded by Medicare through the federal government, and there's been a cap on new programs since the Balanced Budget Act in the early 2000s. So there's no more funds available to start and fund new residency spots. This new pediatric residency is totally being funded by Sanford Health. All 6 of those residents and all 18 of them, when the residency's filled, will be funded privately by the health system because there'll be no federal dollars for that. 2/3 of our physicians are over the age of 50, and 20% of our primary care physicians are approaching the age of 60 and or older. So you can see that we have an aging physician population that's not being replaced very quickly. Part of the reason, the other problem that we're struggling with primary care in South Dakota is that students come out of medical school with roughly $150,000 to $180,000 of debt just in medical school education. Now that probably doesn't scare very many of you in the ag business when a tractor is probably 2 to 2.5, maybe even 3 times that in terms of investment. But those students then are looking at specialties. And the average salary across South Dakota for a family doctor is probably anywhere from $150 to $250, depending on the location. The average salary for a surgeon is significantly more than that. It's probably 5 to 750. Students are looking at that and saying, I can pay my debt off a lot faster. If I go into dermatology, I can even make that much, and I don't have any call. I don't have any responsibilities after 5 o'clock. There aren't too many terminal rashes, and that's where they're headed. It's like my dental friends that say there aren't too many terminal toothaches. So it's a struggle to get physicians, and now you put them into a small community where you have call. I practiced for 20 years in Canton. When I started the first 7 years, there were 2 of us. Call was every other night and every other weekend. That's a tremendous burden. And it gets to the point where you can't pay me enough maybe to do that for a long period of time. I was a National Health Service Corps physician and placed in that community. If you don't have a minimum of 4 physicians in a practice anymore, it's almost impossible to get and to recruit to that practice. And a few years ago, that was 3, where if one was gone, you were only on call every other night. Well, now it's about 4. And with all the financial pressures on our practices, with reductions in payment, with the increased expenses of putting in an electronic medical record and all the other technology and all the other things that come with today's practices, you can see it's becoming difficult to attract the best and brightest to go to our small communities. And I only see that as becoming a greater challenge. And we're going to have to work with a variety of providers, whether they be nurse practitioners, PAs, physicians, technology, a variety of things to be able to provide care. And I think you're going to see communities that currently have doctors in them, maybe that doc that's approaching retirement, almost find it impossible to recruit his or her replacement. And then you add in there the gender issues with a lot of women going into primary care. They tend to ask not to work full time because they want to raise a family. So they're working less hours, which means you have to have more bodies in a practice to provide the care that's needed. And they tend to work less years. So those are some of the things. If I were king for a day, what would I do? I'd increase the class size in our School of Medicine yesterday. I would add some more residency spots and probably develop some rural residency spots. We had a rural residency in South Dakota a number of years ago. It was closed for financial reasons. And I would open up some general surgery residency slots, probably some obstetrical residency spots, and expand the ones that we have, because if we get them through our school and into our residencies, statistics show that we'll have a better chance of keeping them in South Dakota and getting them at least in the higher specialty areas to our smaller mid-sized communities, a Mitchell, a Watertown, Aberdeen, Yankton, maybe even a Chamberlain, Vermilion, Brookings, and then we're at least bringing that specialty care closer in most cases to some of our. And then we've got this large black hole that's called the central part of the state that I don't know what to do with in terms of geography and distance, and et cetera. So those are my thoughts about what we need to do with our physician workforce. And I didn't even touch on nurses and PAs. So,
is there anybody that Dan hasn't scared the bejesus out of yet? Because if so, we want. I mean, you've hit on some really profound challenges. I mean, you know, Jay, Rebekah, anything to add? I mean, is there any silver lining to all of this?
Well, I think that, you know, as I listen to Dan and as we experience this at Avera too in the rural communities, these are problems we need to solve. And in agriculture, growing up on a farm, there was many problems my father had to solve, and my grandfather who also farmed. And this seems one of those that I think it is solvable. I think one of the solutions is technology. I do have a happy story that we had a physician come out of residency, and he was looking at 2 different hospitals. Unfortunately, he wanted to work in South Dakota, and one had, and this wasn't a competing, this was all within the Avera, so it wasn't a matter of Sanford or Avera, it was a matter of Avera and a hospital with had emergency in the ICU and a hospital that didn't. And when it came down to it, they chose the hospital that had the technology, even though the facility was in wasn't as nice as the hospital that didn't have the technology. So the moral of that story is it influences recruitment, it influences physicians willing to come out to rural America. And I think when you look at folks and why do they want to practice in rural America, more than likely they're from a small community, they're from a farm, and they want to stay and they want to help the people locally. And I think what I've seen, I've been encouraged from, I spent 2 days with a female provider, 3 years out of residency, and she expressed the same views that Dan just covered is, you know, I've got a young child, I can't work, I can't do the on-call. And that hospital came up with some creative solutions. They do leverage other hospitals and kind of pull docs in. It does take, as Dan's absolutely right, it takes a little bit more creativity and flexibility. It is a dilemma. A lot of hospitals are using mid-level providers and trying to support that, but unfortunately there's supervision rules with mid-level providers, or fortunately, I guess depending on how you look at it, and you still pull a drag on that family practice physician. So they are big problems. I think there's good solutions with technology. I don't think there's a magic pill. It won't get solved tomorrow. Funding's an issue, as with a lot of things, a lot of industries, and it's these kind of brainstorming of how can we do it better, how can we do it differently.
Again, I would perhaps just remind everyone that there are a lot of challenges. These challenges are not new. We've been talking about them for 25 years. They may wax and wane, but in the broadest sense, every single piece of every single circle must be moving independently and be supportive of. In the public policy arena, if we don't have enough healthcare professional students, you can't be successful in assuring adequate access in rural anywhere. And so you've got the payment policy discussion at the federal and state level. You have the training program numbers, again, at the state and federal level. And then you have the investment at the local level that helps to retain and enhances your ability to retain, recruit first and retain later. And then in the probably the other arena, and this is probably more of a focused discussion, and I would guess the systems are having this locally, is what is it that creates the barriers to your success in our regulatory arena? Because those, again, become the advocacy piece at the state level and at the federal level to help change so that you can be successful in again, defining what you want for healthcare and then keeping it locally.
I was just going to add too that one of the other challenges that we have in South Dakota is the demographics of our small rural communities. We know there's an out-migration from many of the smallest of our rural communities, and as schools consolidate and those folks leave those communities, what happens is you get an older community. And now you have an older community that relies on Medicare funding, and Medicare funding, if you look at over the last several years, has been very flat, if not negative. And so that puts, again, more financial pressures on trying to keep a practice open. These practices in these communities are also small businesses. And so there's lots of pressures, and the revenue side of their business is not necessarily increasing by leaps and bounds and not keeping up with the expense side of their business. So it's many times physicians get accused of just whining about payment. Payment does matter in many of these situations, especially in keeping these small businesses open in these smaller communities, and it's a challenge and a struggle.
One thing
Question. Oh, sorry, go ahead, Jay.
I'll touch on quick is when you look at where healthcare reform is pushing hospitals and health systems, and you look at technology, last week I saw some software that was measuring moisture and soil content at 4 inches, 8 inches, 12 inches, 16 inches, 24, and 36. And so on an irrigation system, you could get that root development that you needed. And I was thinking about that. We have that in the healthcare industry, and the Good Samaritan Society does a great job of this and has a new program where as our communities get older and your mom and dad are at home, there's monitoring systems and with connectivity that you can literally watch how many times they get up at night. And it's relatively inexpensive technology, and I think it'll only get better. But as we try to keep folks out of hospitals, as we try to reduce the overall cost structure in healthcare, because we have to take costs out of the system, that means preventative healthcare, that means keeping them out of the hospital, keeping them healthy, make them aware. And as our folks get older, and I'm looking at my dad, I'm fortunate they live really close to me, so I can kind of be their guard. That's not a case in a lot of these small communities, but can you use some technology that's relatively inexpensive to help monitor? And can you give that family practice physician that information and his nursing staff? We didn't talk a lot about nurses, but a key role that nurses will play in the future of trying to drive down that cost structure so we do have adequate health care in our small communities.
Questions?
We do have a question regarding rural areas. We know people with chronic illness and disease have less access to care and often end up in long-term care facilities prematurely. Do you see any improvement to that in the future? And I know that a lot of these questions are layered on top of each other with some of the relevance of what we've been talking about, but improvements to healthcare to avoid long-term immature.
Well, yes, and I think that what we're going to see, especially with healthcare reform as it comes, a shift from individual medicine to population medicine, a shift from individual disease, where I see you and I only worry about the problem that you have when I'm seeing you in the office, to managing your chronic diabetes, your heart disease, your hypertension, et cetera. And using a team approach, using technology, using coaches, nurses, navigators, there's all kinds of names for it. Yeah, and we have to do that because we do need to get some costs out of the system. But remember, one person's waste sometimes is another person's income. And one person's overutilization, or utilization, I should say. So as we drive patients out of the hospital, we now drive them out of a small local hospital to be provided outpatient care. That local hospital has been paid in the past on the number of people in the bed, just like doctors are paid by the number of people they see. And we have to transition to a volume-based system to a value-based system. So now that little hospital gets paid for keeping its community healthy, and it can stay open and provide services that are necessary. Because if we don't transition to that kind of a payment system and drive everybody out of the hospital or drive everybody out of the offices, we dry up the revenue streams. So we got to change the way we look at paying for services. So it's going to become very important for us to do a better job of disease management, population health, et cetera. So.
Another question?
We did have another one, like the ag industry. It seems that medical providers continue to consolidate to capitalize on efficiencies. As rural communities lose their local hospitals, or these rural hospitals are incorporated into larger systems, what responsibility do those hospitals have for educating and promoting available services to keep those towns viable?
When you say the hospital, do you mean the hospital systems or the rural hospitals that were acquired?
I would say it's the rural hospitals, but also those acquiring agencies.
I'll just start with saying in our system, the smallest hospital we have is 9 beds, and the largest hospital we have is the one here in Sioux Falls. And we take very seriously the mantra, the right care, the right place for the right reasons. And right care, a lot of times, as Jay has alluded to, is in the local facility. We're not going to build another 150 beds onto the hospital here to take care of everybody in southwest Minnesota, southeastern South Dakota, and northwest Iowa. It's more efficient to be able to provide that care and figure out ways to provide that care in that local community. So partnering with that local hospital advisory board or local physician community to do technology, to do a variety of things, is really in the best interest of everybody within that system or within that whole vertically integrated healthcare system. And so it does behoove us to work with local communities.
And Avera is not unlike that. And I think when you look at the e-care services I described, one thing we do in small communities, and I didn't address this earlier, about trying to promote that small community, they'll bring classrooms of kids through, and we'll beam them into the two-way video, and you can imagine how kids get excited when they see somebody on the screen. It's a flat screen, high-definition TV that they're on. Those are type of things that we firmly believe that local control, local promotion from that hospital, and that those local hospital boards, even if we're managing that hospital or leasing that hospital or maybe own that hospital, that the community needs to be involved. We've talked about that, I think, this whole panel, about the importance of community embracement of the hospital, and that they use the services, because obviously if you stop using the services, they won't maintain.
I would just add to that very briefly. We were very fortunate in the state of South Dakota because unlike some other rural states, we have 3 very large systems in our state that have made a very large commitment to maintaining access via their networking and their support services. And my colleagues in other states are very envious of that. The affiliations, whatever they are, help support local access. And again, I would reiterate, as Jay has already said too, local support is where it's at. And if you drive by your healthcare facility to go to the next larger, you negatively impact your community in that way. I'm not saying that you shouldn't get appropriate specialty care outside of your community, but if it can be taken care of in your local community, you need to do that and be supportive of that. And I've seen over the years, and it's changed, and it's changing for the positive. When the systems first moved into communities, the communities seemed to feel that they could push away from the table, and it became someone else's responsibility to help maintain access, and not theirs. And now I see that changing, and in fact, the communities are engaging. They're very involved, and they want to be involved. They want the partnership, but they also want local control. And so that's changed considerably in the past 15 or 20 years.
Other thoughts?
Any other questions from the audience?
Okay, then I'll ask the 4th question for the panel, and it really deals with healthcare costs. And it seems like an eternity that we've been looking at inflation in the healthcare arena quite a little bit higher than we see for other baskets of goods. I mean, is there an end in sight to that? We've talked quite a bit about technology and about service delivery. At some point, does that manifest itself in a flattening of the curve, or no?
I think we have to flatten the curve. If you look at the percent of gross national product that healthcare is taking up in this country, it's grown at a rapid rate, and it's now competing against education. It's competing against infrastructure, bridges, roads, highways, transportation systems. Nowadays, it's going to compete with paying off our debt. So we in the healthcare industry have to do a better job of controlling those costs. And there are multiple partners in controlling those costs. Electronic medical records and technology will help us avoid some duplication. Evidence-based medicine is going to help us avoid inappropriate therapy. Nowadays, it's probably more appropriate to treat your back disease in most cases with 6 weeks of physical therapy and watchful waiting, as opposed to going right to a disc surgery. We need to have better end-of-life discussions about whether or not care at the end of life is meeting the needs of patients and individuals and is appropriate. So, and there needs to be accountability among patients and individuals using the system. I can prescribe and be the best diabetes doctor known to mankind, but if my patient doesn't take their medicine, exercise, try to lose some weight, get active, and lead a healthier lifestyle, I'm not going to impact that diabetes at all. And it's going to lead to kidney failure, probably an amputation and some blindness. So it's going to take all of us partnering to make sure that I've informed the patient that they need to be responsible, that we avoid duplication, we look at the care that we provide and is it appropriate, and that the other thing that Americans are very good at is, I don't want to wait, I want it now, and I want the best. And we have to think about that as we start to talk about healthcare. And we've got the best acute care system in the world. We don't have the best preventative services in the world, and we need to work on that as well.
You know, your question was, is there any end in sight? I think the right discussions are happening with healthcare reform, whether you agree with the legislation or not. There's parts I think that everyone can come around and say, yeah, that's the right idea. It's really critical that, and the last part of what Dan said about personal accountability, it really has to be where individuals take accountability for their health. Health plans have been doing this disease management for quite some time, trying to drive down their cost curve for employer groups with chronic disease programs and health coaches, and you've kind of got a time right now in the next 3 or 4 years where you got everyone looking at this as it should be, and it should have been done probably 10 years ago. So I think we're at that tipping point, but I think you're going to see costs rise over the short term here, a year or two, until we really figure out what accountable care organizations are going to do, the new legislations that comes into effect. At the end of the day, it's all of our responsibilities, and it will be painful. As any cost reductions, it's going to take income away from those that are making a business out of it. But it has to be done. It has to be done for our kids. Just as our debt, healthcare costs are mounting and continue to mount. So it's a good time to take action, and it won't be painless.
I would add to this that in the cost discussion, in the cost arena, we're really having a macro discussion at the federal, who the third-party payers are, who pays for your health care versus what you pay for your health care, which is your insurance premium. So there are two different types of cost factors that go into this discussion. But I would go back to what Dr. Heineman talked about earlier. We're talking about fundamentally changing the healthcare delivery system in our country and moving from a utilization-based, volume-based model, which pays you on numbers. If you see 18 people, you get 18 paychecks, versus a value. And if you have a cadre of diabetes patients and you're paid to manage that cadre of care, and it behooves you to keep those people well, motivate them to stay well. Of course, they have their own responsibilities to stay well. But that is a fundamental shift in the way that our health care is done. And Dan referenced it earlier. You know, it's kind of like we want it now, and we want it here, and we want the best, and we want the most, and we don't care who's paying. And that's the shift. It's a shift in the healthcare arena. It's a shift in the patient arena in that whole cost discussion. So I agree with Jay. We're going to see costs go up before they flatten out and go down because of the change that will have to happen within the system of delivery, not in the care that you get.
Do we have a quick question or two? Yeah, right here, Rebekah up front. Oh, hold on, Mike's coming.
I'm right here.
I'm Rebekah Rink. I'm a veterinarian in Huron, and the discussions are very, very similar to those that we have in our profession. My question would be, because it's my question to those training new veterinarians, is are schools doing a good job of, medical schools doing a good job of training new doctors to do what you're talking about in changing the way they're going to practice? Or are they still teaching on a case-based, treat this disease this way? That's my question.
Really interesting question.
The answer to your question is yes. In fact, the Sanford School of Medicine at the University of South Dakota is embarked on a curriculum change. It started at a process last summer. I sat for a day and a half listening to that curriculum change. They're going to go to case-based learning. They're going to get away from the classroom, butts in the seat lecture. When I did medical school a number of years ago, it was morning was biochemistry, the afternoon was anatomy, and in the lab. And a physician does not need to know the Krebs cycle in glucose metabolism to be a really good doctor. They need to understand nowadays the biochemistry surrounding genetics and genomics. And so we need to change, and to answer your question, our medical school in South Dakota is changing. It's also adding a lot of courses on in fact, there's a lot of team-based learning at the School of Medicine. The anatomy class has physical therapists, PAs, and I believe some occupational therapy and medical students in it. And it's changing significantly now. There's courses on value, safety, quality, and these are like planting the seeds in our practices. These are going to be the people who understand the change when they get out into the practice with us. Older docs are going to be driving us to make more changes. It's just they're not going to get there fast enough.
One more. Good question. See, that's what happens. Anytime you say one more, nobody wants to be the last question. I should have said three more and then just stopped at one. But
excellent conversation. And if we're close to wrapping up, I just have two housekeeping things to mention real quickly. Thank you again to our panelists this morning. If there's some, we are missing an Eisenbraun and Associates portfolio. So if somebody might have mistakenly grabbed a black portfolio, all you have to do is just drop it off at the desk out front, and then our lunch will be just next door, Dusty.
okay, lunch is next door. For the media folks in the room, the panelists will be across the hall in the media room immediately following this panel. If you do want to interview them, that's room 11 over there. A reminder that the information on the South Dakota Marketplace was put at all your tables. And let's give the panelists a large round of applause for their help.